Good afternoon, welcome, and thanks for joining us for today's HIS Talk webinar, Improving Patient Outcomes with Smartphones, UW-Medicine Valley Medical Center's story. It's brought to you by Voalte. I'm Lori from HIS Talk and I'll be moderating. Before I introduce the speakers, we'll hear a little bit about Voalte from Alex Brown, who is the Director of Strategy at Voalte. Alex?
Thanks, Lori. Hi, everyone. So briefly, I'm going to just give an overview of Voalte. We were founded in 2008, and the product that UW Valley Medical Center has deployed and we'll be discussing today is Voalte Platform. It's a healthcare communication solution to allow care teams to securely communicate via voice, alarms, and text messaging across the continuum of care. We have 4 high-level solution categories: our collaboration solutions, Voalte One, Voalte Me, and Voalte Messenger, that allow end users to securely text, make voice calls, and receive alarms and alerts. We have our management solutions that allow for administering the system, Voalte Admin and Voalte Connect. Our analytics solutions, which is Voalte Insight and our reporting database, and our integration solutions, allowing for connecting to existing systems through our alarm integration gateway and APIs and SDKs. When deploying Voalte, sites have a choice of options from deploying the Apple iPhone, which UW Valley Medical Center will be discussing today, to other enterprise Android devices like Zebra's MC40, Honeywell CT50H, or the SpectraLink Pivot. Additionally, we also have a fully web-based messenger client for desk-based users, and all of this runs on the Voalte platform infrastructure for a shared directory, so that regardless of which device you choose, you can securely communicate with the rest of the care team. Voalte itself has 275 plus customers using our solutions across the United States, 48,000 plus Voalte smartphones deployed across those customers, with over 132,000 caregivers using Voalte solutions to provide enhanced patient care. And we're really proud to be ranked by KLAS 3 years in a row. In 2015, we were classified as the most robust interfacing in a secure messaging report. In 2016, we were rated the top platform vendor for care team communication. And finally, and most recently, we were rated #1 in secure communications by KLAS in our platform category. I'm going to turn it back over to Lori to get the rest of the presentation going.
Thanks, Alex. Okay, we have 2 speakers today. First up will be Wayne Manuel. Wayne is the UW-Medicine Valley Medical Center VP of Strategic Services, and he's been there for 2.5 years, first as Chief Information Officer and currently as Senior Vice President of Strategic Services. He maintains responsibility for IT in addition to several other departments and functions across the hospital. Joining Wayne will be James Jones, who is the VP of Patient Care Services and Nursing Operations, also at UW-Medicine. James is an active industry and organizational spokesperson with UW-Medicine Valley Medical Center, which is the largest nonprofit public district hospital in the state of Washington. Since joining the organization in 2014, James has been one of the driving forces behind its strategic and operational mobile communications strategy. And with that, I'll turn it over to you, Wayne.
Thank you. Hello, everyone. Thank you for the nice introduction, and definitely we're honored to speak at his talk today, so thank you again. As stated, I've been here roughly 3 years at UW-Medicine Valley Medical Center. If you go to at our next slide, we were, as you stated, we were actually looking, coincidentally, I was actually on an airplane flying and reading a nice magazine and read about an article from Texas Children's Hospital, who had spoke about how they had converted all of their hospital to an iPhone-based solution on the Voalte platform, and how that had improved the communication at a minimum and also reduced the noise. And through doing some additional due diligence, I actually reached out to Voalte, and we actually ended up speaking to Cedars-Sinai and several others who had also implemented Voalte, and they had actually proclaimed some of the similar savings. And so we had opportunity with a lot of our Cisco and SpectraLink phones that were still out that were very, very noisy, and James will go into more detail about that, but we had a clear opportunity. So then I started parting with our CMO and CNO, and then also James as the VP of Patient Care Services Operations, to look at the value proposition of a new nurse mobile strategy, in the organization. And so that's the foundation for this presentation ongoing. So Voalte is a 320-bed acute care hospital, community hospital, as stated, largest nonprofit healthcare provider between Seattle and Tacoma. We're proud of our little organization here, and we are a member of the UW system. We serve over 600,000 residents, and there's 90 plus languages spoken. We have 9 plus, actually this is probably a little out of date, 9 plus already because we're growing at such a rapid rate. 9 plus primary care, 5 urgent care, and more than 36 specialty clinics and growing. We have a family residency program, and then across UW we are recognized just for our low turnover, very high employee engagement in the organization as the UW Medicine Entity of the Year in 2015, amongst many other very, we would say, respectable accolades and recognitions. So we're HIM Stage 7. We've also been recognized actually on the very leading edge of the LGBTQ community, most wired, and additional well-known for our joint replacement and stroke programs. So very, very proud of our organization. On the next slide. So I talked a little bit about the background, and we were needing a mobile strategy actually for the hospital side that actually carried on that we'll talk about, that we're actually potentially continuing this on into the clinic network as well. And so there's a potential opportunity for us out there. But our initial goal was reducing noise and improving communications, especially around quality, where James had a very specific vision, but also in finding ways of how this might help us down the line, which we're still working on, with improving length of stay. And so our thought was evolving this tool set to include not just nursing, but the physicians who had their own devices or pagers, security, environmental services, the residents, and various other key clinicians or discharge planners or social workers or case managers. So our thought was to connect all of those organizations, individuals, through a tool, just partly based on our learnings from UCSF and Cedars-Sinai, and to improve communication. And I think you'll see in James's presentation that we have definitely done that, and we're seeing our HCAP scores and others improve on the nurse communication and other forms. So it's been a great solution for us. Voalte did a fantastic job actually partnering with me and James and others to actually come in and assess, speak to actually all of our units, and provide an overview of the tool set before we even committed to anything, to help us build a business case based on their previous success. And then of course they openly allowed us to connect to a number of their customers, so they helped us build our return on investment that we expected to have for this, and then and really helped build a really strong executive sponsorship throughout the entire organization, whether it be the CFO or CMO, CNO, myself, and others throughout the organization. We at UW Medicine, we actually use what's called our UW Medicine Patients Are First strategic pillars. There are 4 pillars. They directly align with what people know as what's now the quadruple aim versus the triple aim. But providing the highest quality care, lowering the total cost of care or practicing fiscal responsibility, improving the patient experience, of course, population health, but also becoming an employer of choice. And so that's been one of our strategic goals, which is related to improving the clinician and staff experience. So it aligns, we actually built our business case on all of those. I brought to bear to the organization a new way to score all of our initiatives. So not just IT projects, but also all of our facilities projects, all of our service requests and everything, and more than willing to share with others out there, and did that in co-development with one of our key clinic network leaders here. But it breaks it up, a scoring mechanism based on our 4 strategic pillars to help guide all of our work. And so we actually scored this particular effort for nurse mobile and hospital mobile strategy, and it scored extremely high in the organization, and aligned also again with the quadruple aim. So I know I went pretty quickly there, but I want to actually turn it over to the gentleman who actually did most of the work. I just got to get some of these things approved. So on that note, I'm going to turn it over to James Jones, who is a fantastic leader in our organization and has done many things beyond this. So here you go.
Good morning, everyone, or good afternoon, depending on where you're at this point in time. I'm James Jones. I'm the Vice President of Patient Care Services and Nursing Operations at UW Valley Medical Center. And I'm going to really talk about the project, where it began and where we're at today at this point in time. So I want to start by giving you a little bit about myself. My background is I have my MSc in informatics also, so this project was very passionate to me for us to really move it forward and to be successful as an organization. As Wayne alluded to in relation to the triple aim and the outcomes we're trying to achieve, and also really improving our clinician satisfaction from that perspective also. Been here about 2.5 years. A lot of great work has been done, but this is my little baby, as I call it, from a project standpoint. So I just want to get started talking about where we're headed with the project and what we've done so far. So I want to start with our project goals at this point in time. So our project goals, me and Wayne talked about extensively, was to have a single HIPAA-compliant communication device. And understanding that we need integration with Epic Rover, which we had that already in-house from Epic's electronic health record, which is Epic's electronic health record application. But also understanding that Connects All middleware was crucial to our success also. And what we did do from a standpoint, we moved from emergent middleware and Cisco phones to Connects All middleware and the Voalte solution with the iPhones. We felt this was very pivotal for our success long term. But also integration with the nurse call system, patient monitoring, and our PBX, which is our hospital switchboard. However, there's a couple things we really focus on. We're really understanding how do we improve the clinician and patient experience? What was our biggest challenge? And then how can we achieve that? So with this project, we really looked at reducing interruptions, having gainful workflow efficiencies, and saving time for our clinicians. Because we felt like if we were able to do this, we would give them more time at the bedside with the patients, is what we really were trying to achieve in improving outcomes. And also better communication between the interdisciplinary team, because we knew we had significant opportunity there. Last but not least, really at least meeting and hopefully exceeding the Joint Commission's National Patient Safety Goals for staff communication and alarm safety. That was really important for us, as Wayne alluded to, from our matrix with operational and regulatory efficiency from that standpoint. But when you really look at improved quality outcomes, this was a big deal for us. The major impetus for us behind this was to really improve in 3 key areas for us as an organization. We looked at skin integrity events, which this could be misleading because it does include pressure ulcers, but also includes abrasions and lacerations, moisture issues with skin. So I'll talk about that a little bit more later. Also, secondly, fall and slip events, which I'll speak to a little bit more later also, with significant opportunity how to improve that, and reduction in medication errors for us, which was pivotal, we felt like, also for our long-term success. However, moving to the next slide, we really want to bring it home. This is a great representation of what we're trying to achieve. Me and Wayne both love this slide. Too many communication devices. When we started this journey as an organization and connecting with our clinical staff, we really like to connect to the why and why the Voalte solution was so important for us to implement. And to us, this photo speaks volumes for us visually, and it resonated mentally for what we're trying to achieve long term as an organization. The removal of disparate communication devices, which to us was the bulky tool belt as seen on your screen at this point in time. And the staff got this on several occasions, and even one nurse told me it was an aha moment for her because it clicked, which was very powerful. So we knew we were doing the right work, and they could totally grasp and understand what we were trying to achieve. And we felt like that would help our implementation long term. Because one thing also one nurse said to me at one point in time, she felt like her work is so heavy already, and anything we could do to lighten the load would be greatly appreciated. So we used this slide, this picture, to really simplify why we're transitioning to the Voalte solution on a single platform and how it can improve our outcomes from that standpoint. So moving to the next slide, really looking at the Voalte platform and how it enables the use of Epic Rover. So let me take a step back. So in 2012, we implemented Epic's EHR in our organization. So we understand that we had that capability already. But we also, right before the Voalte implementation started, about 6 months before that, we implemented Epic Rover. So we had the iPhone, we implemented Epic Rover on the iPhone. So we had that also. So from that standpoint, we knew we were moving in the right direction. But we need to, from my perspective and the senior leadership perspective, we felt like we needed a gap closer, a gap communication closer, and the Voalte solution was that for us. Because we're really trying, from a gap closer perspective, trying to improve clinical communication and alarm management, really by providing our clinicians with a unified platform that seamlessly integrates with voice over IP, secure texting, and alarm management and nurse call alerts. And really understand it, being able to have access to the EHR data via the smartphone device for real-time clinician clinical review. That was really important to us from that standpoint. But with understanding this Epic Rover, we really want to start out in a phased approach with our staff and say, okay, right now we're really only going to focus on wound care photos and documentation with Epic Rover at this point in time from that perspective. So I just want to give you a little background on why we felt this solution was so important, and I will go into a little bit more how we utilize the solution to really help improve outcomes. So moving on, the Voalte platform implementation. So as our senior leadership team spoke about this in our operational Voalte implementation team, we felt for us to achieve or to maximize our outcomes, we felt that we needed a phased rollout approach. A Voalte 1, which is the shared handheld device, and Voalte Messenger, which is the desktop client device. Traditionally, our unit secretaries in the pharmacy utilize Voalte Messenger, and Voalte Me is the actual app for clinicians on their own personal device. So, but we wanted to really take a hard look at how could we get the most bang for our buck. And what we did was we had a pilot unit, 3 North, which is our renal respiratory unit. And we looked at 3 North, it's our biggest and our busiest unit. And we felt like if we can make inroads on this unit, we could be successful throughout the rest of the organization. So understanding that, there's a couple of things we had to add to this picture though. With 3 North being so busy, we had to get some outside perspective from key stakeholders to really understand the workflow and communication opportunities. Knowing that we're going to go to phase 2 eventually, which is house-wide rollout to all clinical inpatient care areas from that perspective. So we had the ED charge nurse. We felt like this was really important from a throughput perspective from the ED and communicating with 3 North unit. And the CARS is our clinical administrative resource, which is basically the equivalent of a house supervisor, nurse house supervisor at most facilities. We felt that that was very pertinent because they oversee the house, and we need them on the Voalte 1 phone also. And the stat nurse also on the Voalte 1 phone because they respond to all rapid responses and codes in the house. And when you really think about environmental services, as far as throughput is concerned and turnaround time, it was pivotal for them to be on also. And security, because we have code grades and we really want to look at our response time with them and how we're communicating and managing behavioral type situations. And obviously our discharge planners and hospitalists, because we really want to understand where are our opportunities for improvement with length of stay and communicating, meeting the patients and family needs as they get closer to discharge from that perspective. So I want to move along and talk about better patient outcomes and lowering costs. So getting you up to speed, so we're on the pilot unit. We're live on 3 North at this point in time. But one thing we looked at when we started this process, the pre-implementation, estimating outcomes and trends. This was a big deal to us. So we really looked at all the communication or disparate communications devices that we had in-house already, and we really want to understand what we were trying to achieve from an ROI, for return on investment perspective, and how do we get there. So what we did here, as you look at this screen, there's a couple of things we looked at as I referenced them earlier. Skin integrity, fall and slip, and medication errors. We estimated savings of about 5% soft costing reductions off our actual spend of these events based off of the last year's data. We felt like we would be able to get more, but we didn't know what we didn't know at the time. So we wanted to be very realistic, and we also felt that we could achieve more, but we really need to understand and be thoughtful on how we're communicating to our staff and our senior leadership of what we were doing from that standpoint. And also understanding we're in an era now where pay-for-performance value-based purchasing are here to stay. And as we know, reimbursement is dwindling, and we want to make sure we're maximizing our opportunities here also from that perspective. So that was really important to us. So just a little bit about this slide, a little bit more about this slide. So you can see the skin integrity grand total is 93. It was for last year, and 4.65% reduction there. Estimated cost per event for us was about $37,800, with a total estimated savings of 175, or basically roughly 176K. And you see the same thing going across from left to right for the savings for fall and slip, about 219K in the medication errors. We're expecting about 26K for the year, which brings us to, that brought us to a total of roughly 421K of annual savings, what we expected for inpatient med-surg units after a year's time, based on monitoring these on a quarterly basis. So I want to go to our next slide and then talk about on 3 North. So just remember, as I move forward, I was just talking about house-wide cost savings, but I really want to look at 3 North because this was our pilot unit, and really take a deep look into what we saw there and how we can improve on the communication with Voalte and the workflow and our practices overall. So as you can see, 3 North. So this is our data here. What we did was originally, when I did a presentation for Voalte at their user experience conference, I had a 3-month segment there. But what we did for this presentation is we looked at up until, as you can see, for skin integrity, we went up until February of 17. We had the data for that. You can see we started the pilot right about May, June of 2016 on 3 North. You can see we had a initial little spike, then we had a dip, but then we went back up. As you can see, right around July 16th to August 16th, we spiked up to about 2 skin integrity events. But one thing you'll notice, right about August, we took a steep decline in the right direction for about September 16th to November 16th, which was great for us from that standpoint. So we were showing remarkable improvement for 3 North. And if you look at hospital-acquired pressure ulcers, you can kind of see the same thing. We were doing well with pressure ulcers already for the most part, but what we weren't capturing, I can tell what I do know from looking at this data is we weren't deciphering between, when we talk about skin integrity events, deciphering between the difference between pressure ulcers, skin integrity events, because we want to parse those out and understand those a little bit better. So that's kind of the culmination of this slide, and separating those and seeing the difference between those two. Because originally I spoke to what we did early on, we just looked at general skin integrity, but there was opportunity to really look at more of a granular level and understand the difference between the two and how our outcomes were moving forward in comparison to what we thought originally. So here look at right about November 16th to December 16th, we started dropping in hospital. Our hospital-acquired pressure ulcers started declining again, which is really great, and I'll speak to some more of that. But I really want to go to the next slide at this point and really talk about the monitoring trend events for falls and medication error events. This is really interesting. A couple things here. As you can see, our falls and slips. Right about when we started the pilot May, June, we did kind of take a decline, but we also went up July 16 to August 16. So we had some up and downs, as you can see, but we had a huge spike starting about October 16th till February the 17th, which we actually attributed to a couple of things. We actually had this past fall unprecedented high census in this region of the country. And we realized, when we look back at the data, we realized our opportunity was really around, we need to have better onboarding of our flow pool agent staff and travel nurses, because we were boarding patients at a significant rate, and our policies and getting them integrated into our policies and practices during the high census time really wasn't that great. So there was our opportunity to really improve upon that to help us be successful. So we look at really moving that forward in the future, understanding that, okay, at a certain point when we're boarding with our census management plan, there are certain things we need to do from an organizational standpoint to help us be successful, understand that the technology that we have in place. And also, you can see the last thing here, our medication errors continue to trend down in the right direction. So monitoring the trends and moving to the next slide. So post-implementation on 3 North. So what we looked at the data all the way until February. So now you're looking at where we currently live right now. There's a couple things you're going to notice that, as I alluded to earlier, hospital-acquired pressure ulcers and skin integrity are separated. Fall and slip events and medication errors. And you look at the numbers from January 15th to June 16th, we looked at 18 months. But what we did with this pilot unit, 3 North, since they went first, is we looked from when we started the pilot, right around July 16th to February 17th, we started looking at our events around that time. As you can see that over the 8-month period, our hospital-acquired ulcers continue to decline. Our skin integrity events also declining. However, as I alluded to on the last slide, our fall and slip events rose due to the high census and us not having consistent workflow and practices in place. But what's so interesting about it, as we dug into the data, we really realized, so when you have falls and slip, and we estimated a cost savings that was significantly higher, but we realized when you have falls and slip, the opportunity there from an impact standpoint is monumental for the patients for several reasons. So falls and slips, typically when they fall, the physician does not discharge them. They stay 2 or 3 days longer depending on the severity of the injury, which increases our length of stay. And there's other testing procedures that go into this. So just from a cost perspective, when we recalculated our return on investment, now we're showing just for this unit alone that annual savings of $20,000 estimated savings for the year just for this one unit, which we, if you remember, we talked about $420K overall for the entire inpatient area. So we have an opportunity to improve on this, and I think we will eventually reap the benefits of this. However, there's some things we have to put in place because we didn't know what we didn't know at that point in time from that perspective. So we see the opportunity. I think we will make inroads with this to get us where we need to be in relation to implementing the right practices on the units from that standpoint. So next, I want to move into the next slide, and I'm going to break down, I'm kind of going to go through hospital-acquired pressure ulcers, skin integrities, fall and slip events, and medication errors, and really talk about our clinical workflow and what we're doing to achieve the maximum outcomes. So hospital-acquired pressure ulcers and skin integrity events. I combine these. We separated them on the graphs, but I combine these because they are all under skin integrity events, but they are different. But the way we work and practice in regards to managing them is pretty much the same with our Epic Rover and our Voalte solution. So as Wayne alluded to earlier, everything we look at, does it bring value to the organization? So we look at a value-based clinical workflow. What we're able to do at this point in time with having Voalte, being able to communicate in real time and to upload pictures on Rover and be able to communicate amongst the interdisciplinary team is pretty powerful. And I'll give you a prime example of that. So we have 2 full-time wound care nurse practitioners for a 321-bed facility. So basically, they're more of a consultative service. We wish we had more, but we don't. But this has been monumental for our wound care team because one of our wound care nurses said, you know, for her, it transitioned from the Foot Express to the Time Express. Now they can have more of an impact and utilize their time more appropriately with the staff. In particular, I'll give you several examples of what we're seeing. And remember on our graph that the pressure ulcers were trending down, they're going in the right direction. Also the skin integrity events. So what we see a lot of now is it's no more the, well, I'm walking around the hospital looking for the physician or looking for the nurse. Now they're able to text and know if they're available or busy, and then when they can meet to look at a wound. Or if the nurse can take a picture and send it to the wound care nurse, and they can talk about the plan of care and change the treatment plan in real time, which we feel is very powerful. And it improves that communication and also tying the patient and the family into what's going on, because the nurses are also able to show the patient the picture that they've taken in the patient room and building that relationship and understanding what we're trying to achieve as a group from that standpoint. But when we look at the interdisciplinary collaboration, I think this is really key. One of my wound care nurses said to me, when she's rounding with the physician, she can tell if they've looked at the wound or not just by asking the question, because most of the time she's saying they don't look at it, but she could pull it up and show them, so they can get on the same page. And so it keeps everybody honest with the expectations of the job, which is pretty powerful for us also. But to be able to text each other in real time, regardless of where you're at, and communicate, it's just really powerful for us as an organization. And we really look at workflow because we know all our time is limited, but able to be on our CCU unit, our critical care unit, and get a picture of a patient's wound on 3 North, and to be able to look at the picture, pull up Epic, and then be text on phone and never have to talk to each other. It's pretty powerful for the wound care team and the nurses. And our nurses are taking pictures at an alarming rate, I feel, but our wound care team thinks it's a great thing that they're doing. So we're catching everything. So we're also, from a workflow standpoint, implementing what we call is 4 eyes in 4 hours, where when a patient goes to a unit for the first time, the 2 nurses will come in and do a full body assessment of the patient, and they will look at the body and take all the pictures and send it to the wound care team or consult with the physician at that time. So I just think this is a very powerful tool in being able to communicate and improve outcomes from a clinical workflow standpoint. My favorite, fall and slip events. As I alluded to earlier, remember we had a significant spike in fall and slip events, and we've already started remediating some things in relation to fall and slip events. So one thing we had to understand as an organization, from a culture change perspective, how do we reduce cognitive overload for our staff? So we knew the Voalte solution was coming, but there's some things we did early on with the understanding that we were going to implement. We made sure we had the right culture and set the right expectations on the unit. We achieved this implementation by really implementing appropriate shift-to-shift handoff and hourly rounding before implementing the Voalte solution on the unit, which was pretty powerful because we knew that we're going to design the alerts and alarms the appropriate way. But there are some things that, from a safety check standpoint, that we had to put in place that the nurses knew they were comfortable with what was going on with the patient, and we were setting them up for success. But the key here was managing the alarms from the Raleigh nurse call via ConnectAll to the Voalte smartphone. And for us, what made all the difference in the world, we divided the unit up into 2 teams so the nurses in the closest proximity responded to the alarms for better response time and improved culture of accountability. So they knew when the alarm was going off, this patient was close to them by dividing that unit into half. So what we get is, if you could visualize it, if you're a clinician, if you could visualize, so we had a C and a D side. So in a fall, a patient was going to get up, or they were getting out of bed, the alarm would go off. It would only go off on that side of the unit, which the staff knew, hey, I need to respond to that. No longer do I have to go to the other side of the unit where it's 50, 60 feet away and I have to worry about that. It's on my side of the unit, so I will respond. And it really created accountability from a peer pressure standpoint, where they were able to see each other and the alarm was going off, and they knew, hey, we all own this process, we're all accountable, which was pretty powerful from that standpoint. But also what's really helped us is the escalation pathway for alarms. So if the primary nurse is unavailable, we had the secondary or the buddy in the system that would contact them. If they were unavailable, then we would have the backup, which traditionally is the charge nurse. So really understanding that escalation pathway, but also letting the staff know and be involved in this process of how we were designing this was pretty impactful. So they understood what was going on from the escalation pathway, so they felt comfortable, and we created a culture of transparency and ownership that we're all responsible for this. And I think that really helped us from a fall and slip perspective. Even though that we had that spike, I think we will continue to trend back down now that we understand where our opportunities were from last time. So moving to medication errors and events. As you remember, medication errors are continuing to trend down. I think this is a pretty easy trend down for the nurses because if you really think about it, a lot of our nurses are going into the med rooms. We already had a sign on the door that said, do not interrupt passing meds on the outside of the door. However, now they're able to enter on the custom status bar, administering meds. Then update their profile from available to busy. So he or she will be seen when someone's looking for them in the directory that they're busy, and they will avoid contacting them while they're passing meds unless it's an emergency. As you can see on the screen now, it says busy, administer medications. This is what we see on the unit. And the staff know also that if there's an absolute emergency, that we will come in, but otherwise we do not bother them. But the alarms and alerts are rerouted to the designated buddy coverage, just like our fall and slip events also. And Connexall manages all that for us, but the escalation pathway is really important here from that standpoint. But one thing we did learn about this is making sure, reminding our staff that, okay, when you're done passing meds, make sure you say you're available again, because they forget from time to time. So we do run data on that each month to make sure we remind the staff, because we can look at data and say, okay, when they're coming on and they're coming off of being available and busy, to remind them to be mindful of that is really important. But this has worked very well for us because we know the wrong meds to the wrong patient in many cases have caused significant delays in care and delays in discharge from that standpoint. So we're making great headway with that one. I am really proud of this one because we continue to do significantly better with this. But one thing I want to talk about on the next slide is what I thought was really interesting. Unexpected outcomes and cost savings. So as I spoke about on the last slide, medication errors and events. What, from an unexpected outcomes and cost savings opportunity that we did not realize early on with the status bar, with the added accountability of, they knew we were pulling the data and we could look at it. We keep the data for up to a year, and we knew that the nurses were making their assignments and they were putting it in their in their status bar. However, one big thing in particular, we're in a union environment here, that one thing we really advocate, not because of a union environment, but also because it's the right thing to do. We want our goal is for our staff to have uninterrupted meal and rest breaks, but we also had staff that were not clocking in and out appropriately or not clocking out at all. So this was something we started looking at, and we thought it was kind of interesting from the perspective of we're like, well, why are they missing breaks or why are they not clocking in and out? What was going on from that perspective? So what we started doing is we reviewed it, and I had my clinical analyst pull the data, and we saw that there was 731 hours of missed breaks over 8 pay periods. That was pretty significant, and we pulled this. This is for the entire house. This was not just for 3 North, so I want to be clear about that. So that was pretty significant for us when you look at a cost overall. However, when we start looking at that data, when we were tracking it and trending, we saw some trends from a workflow standpoint that weren't making sense to us. So we started really realizing that one thing, the acuity of our patients weren't being appropriately assigned across the units, which that was a struggle for the nurses to go on their lunch break from that standpoint, because they felt like they need to stay. So that was a challenge for us. And the other piece of that is we want to understand why we're having so much soft overtime, and what did that look like for us from an organization standpoint. Were we giving them the right tools, the right patient assignment, the right equipment to do their job, and the right training from a professional development perspective to meet the needs of their patients? But with the understanding, first and foremost, we're trying to support them in the work that they do, because we can't be successful without them from that standpoint. So I thought this was a really interesting one to me as we were looking closer at it. We've gotten better on breaks and not missing them now, because it's that accountability there and understanding why, which is very powerful for us. So there's opportunities just from a financial perspective, as well as a clinical workflow perspective also, and really understanding what the data is telling you, and then getting in front of your staff and having the real-time conversations and feedback of what's going on. I think that's what we've been able to build relationships and build trust, that we value them as employees. We want to understand why it's not punitive from that standpoint. So I want to talk about, moving on, I want to talk a little bit about more effective, efficient communication, quiet environment, and better staff engagement. So in particular, kind of going back to 3 North a little bit now, with the additional benefits of the Voalte platform. More efficient communication with text messages and replacing voice calls. What we've seen is about 60 to 70% texting now to about 30% calls. And traditionally, the calls are really around now of critical lab results, or giving or receiving patient care orders from the physicians, which is great for us that we've made inroads with that already, and it hasn't been a full year yet from that perspective. However, there's still some opportunity here with that, but I'll talk about the positives first. One thing I think we've done really well here, it probably has to do with hiring also, but we have a very tech-savvy staff here, and they love the solution, and they've adapted to the solution relatively well for us, which also elicits great feedback from them from that standpoint. And one particular 3 North, one particular nurse, I can tell you for a fact, she's our charge nurse. She's still carrying a flip phone, a Nextel flip phone. I didn't even know they still existed personally, but she absolutely loved the Voalte platform and being on the iPhone and what she could do. She said it simplifies her work to a seamless process, and she said we're actually able to take care of patients, you know, basically all through one device, which I thought was pretty powerful. I've also received some direct feedback from staff and patients about the unit just being much quieter. One family member said to me that it's nice to have a quiet hospital that feels like a actual hotel for a change. Maybe my dad actually can get some rest, which I thought was pretty interesting. So we've done some great things from that perspective. But as I look to better engagement from nursing and from the nursing department in the hospital, you can never get enough feedback from them. And I want to say that again, you can never get enough feedback from them, because they are doing the work. They understand what needs to happen. And you always need to seek that feedback from them from that perspective, because their input is very invaluable. They've given us ideas about different opportunities, how we can improve Voalte and working with the team, how we can improve in communication, working with different departments in the hospital from that perspective. But one thing I'm really proud to say is during this time on the pilot unit, this is the first time in my 2.5 years here, pilot 3 North went to the 99th percentile, which was very powerful. That really spoke volumes to us, whether we were doing the right thing with the satisfaction of meeting the needs of the clinicians, the patients, and their families on that unit, would implement this solution, which we feel like, as I alluded to earlier, we'll be able to continue to make inroads with this, even though we had the little blip this last fall with the high census and so forth. So, moving on, next slide. Just generally, improve patient experience. As we know, a couple things I just want to touch base on here. What we've talked about in our organization with the quadruple aim and understanding that if we're trying to truly improve communication and meet the patient needs with the solution we have, and one thing I really bring home to my staff is that we know with Joint Commission, number one cause of adverse care events is the lack of communication, which we're continually striving to improve upon with the Voalte solution, which has been excellent for us so far. We hope to continue to maximize the solution to achieve even greater accomplishments for us as an organization, being only within a year. However, I want to really talk about one key major initiative that we're doing right now. It's called our discharge initiative, discharge optimization initiative. And this is a hospital-wide initiative where we are working on creating more space without adding more staff and more beds. And to be quite honest with you, we're all challenged with that today, you know, with reimbursement dwindling and pay for performance and value-based purchasing. But really looking at this and looking at our Voalte solution, we've realized we've made some inroads with this already. In particular, our hospitalists, they're not geographically located on one unit of like a traditional closed unit within our organization. So they move throughout the hospital to take care of patients on different units, you know, from the renal respiratory unit to the stroke unit to the critical care unit. So this, with Voalte, with the opportunity to really communicate in a real-time basis, is really crucial for us from that perspective. So one thing we're really looking at this is we're trying to pull the data, look at it, and understand where our opportunities are. Like, I'll give you one example. Right now, we are trying to discharge our patients by noon in hopes of decreasing our length of stay. And we're working with our hospitalists, and they have the Voalte phone, and we're tracking and trending the communication of when the discharge order is ready and when the nurse is communicating to them, and when they are also following back up with the nurse to make sure we get that patient out, discharge that patient in an appropriate window. But however, though, it's really interesting what we've seen with this is a lot of it has taken off by itself, because even the hospitals are coming to us now. They're already pushing the envelope. They want to have order sets in Voalte, and they want to be able to do these things that we're not ready for yet. We're still in our first year, as I alluded to earlier. But however, they want to do these things, but we need to be very judicious about how we move forward. And one of the things we realized the discharge optimization project is that a lot of our physicians, once they try to send orders over to the nurses, and it shows delivered or received, so they feel like that is an order. We've been very clear about that. You can't discharge the patient via the phone. We're not there yet. We'll eventually get there. But we still want to have that real-time connection and communication on pieces like that. But overall, the discharge initiative is a big deal for us. And the last thing I really want to touch base on is looking at this slide. You see the image and the communication. This is throughout our hospital about the Voalte smartphone use. It's posted on all our units, and all our patients and families get to see this. So it kind of really understands why we're using this technology, so that they don't feel like a lot of the staff are just on their cell phones. We also, if you can see, on the back of the phone, we have UW Medicine Valley Medical Center, which I will talk a little bit more about that on the next slide, but it just really speaks to what we're trying to achieve with the less noise and more efficiency. And we do have from time to time that some of the patients actually want to use the Voalte phone to call out. We don't allow that, so there's still some opportunity with that. But move to the next slide. As I just alluded to, you can see UW-Madison Valley Medical Center logo on the back. This has helped us actually not to lose phones like we thought we were going to. We've actually had some patients and family members actually return the phones, which is great. Everybody's buying into that. But talking about lessons learned, this is the not so good part, but I look at it as opportunities for us. So lessons learned, we started this project. We realized that we did not have everybody at the table. We need additional operational stakeholders and informatics at the table, meaning, as I alluded to earlier, that EVS was there, but we didn't understand their workflow. Security was there, but we didn't completely understand their workflow. And lab was there early on, but we didn't understand their workflow. And building a better relationship with our clinical informatics team and our CNIO, they were part of the project, but really doing our due diligence and vetting our portfolio project out a little bit better to understand they had the time and the space to really help us. They were involved, but not involved enough to really help us really look at conducting the appropriate workflows and assessments. If we had to do one thing over, we would have them more involved, and we've done a good job, but we would have them more involved. We would have been able to save a lot of time and headaches with very thorough workflow and assessments of the different units, because every unit is a little bit different from that perspective, but to be able to look at that and lay it out in comparison to other units would have been great for us. As I mentioned earlier, solicit providing clinician feedback. Once again, and I'm saying this for the third time, this is really important if you want adoption and continued engagement. Really important. One thing, and the next thing I want to talk about, considering naming of departments of Voalte directory. Now here, this is a little bit interesting because what we realized is you need to have your culture. Like, I'll give you one example. Like, most hospitals I've worked in, it's named the quality department. However, here, it's named outcomes. So we went with quality initially in the Voalte design session, but we actually changed it back because it created so much disruption for our staff because they were trying to find people and they were looking at it in the wrong places. And then like another example is our discharge planners. We didn't necessarily have them under case management because they were kind of separate. So really understanding your culture and how you set up your directory is really important because the staff will get frustrated and they won't be able to find who they're looking for. And as I alluded to earlier, they won't be as engaged and they feel like they will, and some of our naysayers will find any reason not to utilize the platform. So I would be very mindful of those things from a directory standpoint. Stick to your culture. Remember, we had a great strategy, but culture eats strategy any day from that perspective. And next I want to talk about, moving to the next slide, plans for expansion. So right now, we are currently in phase 2. All of our other inpatient clinical units are live on Voalte right now. So that is going really well. As I said earlier, we're learning things by the minute, by the day as I round on the different units. But what we also realize there's opportunity for additional alarm and alert integration video connects all from that perspective. But really looking at ongoing deployment for physicians and residents. This is a challenge for us. Our residents and physicians want to automatically go to VoateMe. However, we want them to utilize the Voalte One phone, which is great. We love the engagement. However, I would recommend really stick to your process and really explaining why you're doing what you're doing from that standpoint, because that's really important for long-term success with the physicians. And there's also a few things that the physician needs to understand. And I would, as I alluded to, recommend that they work with the Voalte One phone first before they go to the VoateMe app. which is on their own device. So connecting to the clinic network. We've talked about this. This is really our phase 3. So what we're doing is really connecting with our clinic network. We feel like organizationally, right now, we're also working on transformation of care through our entire system. And the clinic network for us is the next phase of that, to really smooth the transition of care throughout the healthcare continuum for the patient and the family. We feel like that is really important for us. As we are part of UW Medicine, it is an opportunity, I think, for also being a community hospital, and we're the largest service provider between here in Tacoma, Washington, South Seattle. We feel like we have the responsibility and the duty, and we have the capability to really provide the care that our patients need. And our team is all in from that perspective. So really looking at that, working with our clinic network, and really, in particular, them being on the, whether it's the Voalte 1 or it's the desktop version of the Voalte Messenger, being able to communicate with them real time with our discharge planners and setting up appropriate appointments to make sure they're getting to their appointments if they can't, or setting up something different that meets their needs, that we can make sure we keep them in our system from that standpoint, which is really powerful. One thing we like about that is with the photos in Voalte, we are able to show them the providers or the nurses that will be taking care of them when they move throughout the system. And the patients and families really like that also. One thing, the last thing, really connecting to first responders in our community. As I said, we're a community hospital. We're doing great work. I'm really excited about this. We've been partnering with Voalte on this one to look at how we can improve our communication with our first responders, paramedics, EMS. In particular, right now, we're really looking at our stroke population and really trying to get information early on before they hit our door, because as many of you know, the strokes, the minutes matter, and our door to needle time continues to decrease, but we feel like there's an opportunity to get information via our HIPAA-compliant device, and having our partners outside of our walls have this technology to help us transition them into our hospital more efficiently from that perspective, so we can expedite the care long term for them when they hit our when they come through our doors from that perspective. So, in closing, I just wanted to really talk about Voalte overall. I think personally, Voalte has been very successful for us as an organization, and Voalte as a team has been very receptive for us in relation to being on site with us, really helping us transition and having their team here to help us understand all the intricacies of the solution, along with Connexall coming here from that perspective. And the work that we're doing from a workflow standpoint and clinical perspective, I think we've only scratched the surface of what we can achieve. And I'm really looking forward to working with Voalte and really getting our data for all of our inpatient units. It's the next phase of really understanding what does the big picture look like and where are our opportunities from that standpoint. So at this time, I'm done. So I want to open it up for questions.
Thanks, James. The first question Lois has is, what new workflow with the Voalte implementation directly impacted the metrics for skin integrity and hospital-acquired pressure ulcers? Okay.
The direct workflow impact was really based around having the technology, the Voalte solution, really impacted skin integrity and pressure ulcers, because having a solution, having it at your fingertips, we were able to make real-time decisions. And then we had Epic Rover on there, so we were able to take pictures in real time, and we were able to communicate in real time, which really created a sense of accountability across the organization, as I alluded to with our wound care team. So being able to see the pictures, even if they're not here, they can text back or call in, you know, because the minutes and the time really matter, especially in particular with pressure ulcers, that we were able to look at it. They were able to collaborate on a plan of care and understanding with our 4 eyes and 4 hours that, okay, you have the capability, you have all the resources at your fingertip to communicate, because the challenges we had originally was when we just had Epic, we were taking pictures on a Kodak phone, Kodak camera, I mean, and the challenge was we were taking the picture, it wasn't great clarity with the picture, and also the nurses weren't trained appropriately with that. So really understanding, okay, if you take the picture, if it doesn't look great, the wound care nurse could see it and say, okay, could you take the picture or I will come down. And then that was our opportunity to foster collaboration and to teach at the same time about how to improve, taking those pictures and looking at skin integrity events and what they're seeing. Because I alluded to, we only have 2 wound care nurses. And then that ongoing, that bi-directional communication has been phenomenal. And then they also would be able to text if they could not speak to each other.
All right. Jim would like to know how the implementation impacted the nurse-to-patient ratio.
Actually, how it impacted nurse-to-patient ratio. I'm proud to say one thing we've done here, we have a pretty good nurse-to-patient ratio already. We're actually at 1 to 4 on average already, so we had made that transition even more. And Jim, I'm glad you brought it up, because one thing we really talked to our staff about was, okay, these are the things we've done to set us up for success. We're a primary nursing model. These are the tools we're giving you to be successful. So we want you to own the patient, because we knew from a nursing perspective that if the nurses own the patient, they have the tools to do their job. Traditionally, you see outcomes are better from that standpoint. So that's something we really bring home from that standpoint. So we had already reduced our nurse-to-patient ratio, but we also looked at one thing we did, we looked at our acuity of patients a little bit closer, because we could see, okay, which patient alarm was going off more often than not, if they're a fall, but then looking at isolation patients, and then really looking at that data and working with the staff with the hourly rounding and the bedside rounding, and taking all that information and then say, okay, we need to have better assignments. Even though it's 1 to 4, we need to have better assignments across the board, because the nurse cannot spend all her time in the isolation room or have 3 patients that are high risk for falls.
As a follow-up to that question, with the direct communication now, are the nurses spending more time at the bedside rather than at the nurses' station?
Yes, I could tell you in particular 3 North, I actually see them, they used to really hover around the central nurses station, but when I walk the units now in the manager and they do rounds, the nurses are really located next to their patient rooms now. And they're very close to them. And I've actually walked by the rooms and I see the nurses actually showing, like in particular, I talk about the wound care, showing the patient the picture of their wound and then discussing what's going on from that standpoint. So it's no more running to the desk of having to answer the phone. They can get the calls on their Voalte phone. And we're also set up to be located near the patient already, but they're also able to text. In particular, the unit clerk is able to text the nurse down the hall. The nurse doesn't have to walk up there anymore, because they have Voalte Messenger on their desktop. So all the walking, and you're thinking about time and space and wasted energy and efficiency. So that's been very impactful for us also.
Terrific. Well, this has been a fantastic presentation, and it's gone longer than we usually have, and also there are a lot of questions out there. So what we're going to do is we're going to conclude the webinar, but the Voalte people and the speakers, whoever's most appropriate, will respond directly to all of you who have posed questions that we weren't able to get to today. I want to thank all of you for joining us, and thank you, James and Wayne, for the interesting and very informative presentation. As a reminder to the attendees, watch your email for links to the recording of today's webinar, as well as the PDF version of the PowerPoint presentation. We look forward to seeing you all at our next HIS Talk webinar, and I hope you enjoy the rest of your day.